So we are looking at anesthesia or anesthetic agents. So anesthesia comes from an means without, and then aesthesis means sensation. So basically meaning without sensation. When anesthesia is being given, it means you are giving so that someone shouldn't have sensation or so that they shouldn't feel anything. So the drugs which produce reversible loss of all sensations and consciousness, we call them anesthetic agents. So it's important to understand that they produce reversible, it shouldn't be permanent loss of sensation and consciousness. And these ones, there are people that are specifically trained, the anesthesiologists, which will be able to administer anesthesia. Now, when anesthesia is being administered, number one is to induce anesthesia and to maintain anesthesia. To induce is to start the process of stopping all sensations and consciousness, and also to maintain. So the anesthesiologist will be able to do that job. Now, when you look at anesthesia, it's of two types. There's the general and the local. General anesthesia is going to take someone unconscious. Basically, is going to shut off the entire body. A local anesthesia is just to numb an area so that you don't just feel pain on a specific area. The differences between the local and the general anesthetics: for general, it acts on the central nervous system, like the brain and the spinal cord, so it will be able to knock off near the entire body. And then local anesthetic works on peripheral nerves that are supplying only an area of the body. So for general anesthesia, it involves the whole body, while local anesthesia is restricted only to an area. In general anesthesia, consciousness is lost, meaning you can't tell what's happening. You are gone, right? But in local anesthesia, consciousness is going to be okay, like you are fine. For example, someone can be in the labor ward, they are given local anesthesia that is just going to, like the spinal anesthesia. So that one is also local. It will only numb the area below the umbilical. So they are talking, but down you've cut them. All right. So that is local. They are still conscious. Like one patient, while in the labor ward, was even saying, "Oh, you doctors, you even managed to eat what you are seeing there." But this is something that is big happening there. But she's there. All right. So that is the local. And then for general anesthesia, you prefer it for major surgeries. For example, you want to do big surgeries, like, let's say, of course, things like delivery, local anesthesia is just okay. But a big surgery, let's say you want to remove a very big mass from the body, someone has got a very big fibroid, you want to just switch them off, all right? So for local anesthesia, you can't use it. Though you can use it, but for big surgeries, you don't prefer to use local anesthesia. And then for poor health patient, general anesthesia has got some form of risk. Okay, there's going to be poor health. While local anesthesia is usually safer, it's only affecting an area. So even at the end, after you are done, it will basically be okay. But for general, well, because you are numbing the entire area, something bad can end up happening actually, because you're also stopping the respiratory muscles. So someone can't actually even breathe by themselves. You have to assist them in breathing. So there can be some poor health outcomes. Okay. For minor surgeries, you prefer using local anesthesia than general anesthesia. Now, and for general anesthesia, there is a triad that general anesthesia follows, and that includes hypnosis, analgesia, and muscle relaxation. For regional anesthesia, there's only analgesia and muscle relaxation. So hypnosis is basically taking someone into sleep. Okay, taking someone into sleep. So for general anesthesia, you go to sleep, and then there will also be analgesia to stop pain, and the muscles will relax. But for local ones, you don't go to sleep, but you stop pain and you relax the muscles so that the procedure can be done. Now, an ideal anesthetic drug be smooth, should have a smooth and rapid induction, rapid recovery. So so the smooth induction is when you give it, it should be smooth enough for it to start working, and then there should be rapid recovery. Okay, when you give it and then you no longer want it, someone should be able to, it should be done, and then someone comes back to normal, and then it should have a wide safety margin with minimal side effects. Now, before you give anesthesia, there is what we call pre-anesthetic medications. Before you give anesthesia, give other drugs before. For example, you are going to calm the patient and relieve pain. Okay, and also protect against undesirable effects of the subsequently administered anesthetic or the surgical procedure. So also want to protect, because as you give this anesthetic agent, it might have these bad effects. So you want to protect against all those bad effects. For example, as you get to give general anesthesia, you know that the respiratory muscles are going to be depressed. So want to prepare someone already to protect them. So you give them artificial ventilation already. So you put face masks on them because you know they'll not be able to breathe on themselves. And then also facilitate smooth induction of anesthesia, and also lower the dose of anesthetic required. Okay. So before you give anesthesia, these these other drugs have to be given for the reasons that are mentioned here. In other words, you don't just give anesthesia. You have to give other things before you give that. For example, you need to give opioids. You know opioids are used for pain. So these ones are to basically stop pain. Example includes morphine. Please know also the reason, all right? Because you can see that. And then you also give anticholinergics. Okay, and cholinergics will prevent secretions of fluid in the respiratory tract. So it will protect the heart against the vagal stimulation or bradycardia. So when you give these anesthetics, you can end up depressing also the heart. So it becomes bradycardic. Now the cholinergic nervous system, that's the parasympathetic, it slows the heart rate also. So if you give an anticholinergic, it is trying to raise the heart rate. So it will protect against the bradycardia. So an example you can give is hyoscine, the same one that you use in motion sickness, okay? And also to prevent secretions of fluid into the respiratory tract. So when you are resting, secretions are a lot. But when you are running, you have got little secretions. And anticholinergics work like the sympathetic, so they reduce their secretions because the respiratory system has been depressed. These secretions can be bad if they are accumulating in the respiratory tract. You also give sedatives and anxiolytics. Anxiolytic is a drug that you give to prevent or to relieve anxiety, because when someone is about to go into a big surgery, they are anxious. So you also want to relieve anxiety. Okay, for example, for anxiety, you give benzodiazepines like diazepam. And then you also give antihistamines for allergic reactions. An example is diphenhydramine. And then you also give antiemetics for post-surgical nausea and vomiting. Okay, because after surgery, someone might end up vomiting or have nausea. So I want to be able to stop that. For example, you can give metoclopramide and prochlorperazine. And then you can also give thiopentol. This one is for smooth induction so that the process can start well. Okay. And then for H2 receptor blockers, These ones it will be basically there to reduce gastric acidity. When you give these anesthetics, you can end up producing a lot of acid in the stomach, and so you give these histamine, okay, blockers working on H2 receptors in the stomach, like ranitidine, so that you reduce the secretion of the acid. You also give neuromuscular blockers to facilitate intubation and suppress skeletal muscle tone. Okay, to suppress skeletal muscle tone. Remember, when you are doing anesthesia, giving anesthesia so on to have a surgery, the muscle shouldn't be contracted, they should relax. So to suppress that tone, you can give these neuromuscular blockers like succinylcholine, vecuronium, and the atracurium. So please just take note of these classes of drugs and the reason as to why you are giving them. Now let's start with the general anesthetics, but before we go further, is this okay? Okay. So general anesthesia has got some cardinal features that you need to know. What are the features of general anesthesia? Number one, if you give a general anesthetic agent, there's going to be loss of all sensations, especially pain. So there's analgesia. And then there's also going to be sleep. So someone will go into sleep. Okay. They become unconscious and there will be amnesia. Okay. Like they are just gone. They are sleeping. They can't feel anything. And then there will also be abolition of somatic and autonomic reflexes, meaning that all reflexes, for example, uh, muscle movements or autonomic reflexes like urination, that's autonomic, isn't it? You, of course, urination has got some form of control, but let's say secretions from glands, that's autonomic, you don't control that. All those reflexes are going to be off, like the pupil, pupillary reflex is going to all be off. And then there's also going to be immobility and skeletal muscle relaxation. This is important. Someone in general anesthesia can't to move. Okay, they can't move. Actually, this is the first thing that you'll be able to see. Someone that you've given general anesthesia starts to move, for example in the labor ward, you should be worried. Or let's say you are performing a surgery, let's say the woman has got a fibroid, or let's say any tumor in the uterus, and you are performing a surgery, they start to move, that's a problem. So you have to increase, they actually adjust the dose of the anesthetic agent that they are using, okay, because these guys cause skeletal muscle relaxation and immobility. And then there's also sedation, like you depress the central nervous system, okay, and reduction of anxiety. So these guys shouldn't feel anxious, okay. So the drugs themselves, they've got also that aspect. Now for general anesthesia, you have got four steps or stages that you have to know. When you give general anesthesia, the first stage is known as analgesia. In the first stage, what happens is that there's going to be loss of pain. So the first thing that will happen is that someone will not be able to feel pain, but the patient is still conscious, like you can still talk to them. Actually, what happens is that you even use some instruments to see if they've stopped feeling the pain. You prick them, okay, and then you are looking at them. So, but they are still conscious. That's analgesia. And the stage two, there's excitement. So there's going to be increased respiratory rate. Someone like is breathing very fast. There is also increased irregular blood pressure. The blood pressure is also increasing and it's irregular. The patient may experience also delirium. Okay, like they are getting to be confused, and then they are like they are about to shut off. Okay, they can be showing violent behavior, like they're trying to resist, and then the eye will be dilated and reactive. Okay, and then in stage 3, there's going to this is known as surgical anesthesia. Just know the names and the stage also. Stage 3 is surgical anesthesia. Here now there is regular respiration and relaxation of the skeletal muscles, and then the eye reflexes, they are now going to decrease until the pupil is fixed. Okay, the pupil becomes fixed, and this is the most desired stage for you to be able to perform anesthesia. So if you go beyond the surgical anesthesia, it's going to be coma or death. So here, the medulla, okay, you know that in the brainstem, that's where we've got the respiratory centers, the cardiovascular centers. The medulla is going to be paralyzed, and there's going to be severe depression of the vasomotor, depression of the respiratory centers. So at this point, because it's so severe, death may end up happening. You don't want to reach into stage 4. The stage you want to reach at is the stage 3, where you have got regular respiration and relaxation of skeletal muscles, the eye reflexes decrease, the pupil become fixed, it can't move like that, right? So this is just again explaining the same stages. So again, in stage 1, the analgesia, it starts from the time of administration of the anesthetic and it lasts up to the loss of consciousness. Okay, so in other words, in this phase, if someone is conscious, immediately they become unconscious, stage 1 is done. So at this point, it feels like a dream. Okay, it feels like a dream. You are about to transition, you are no more, and then you are going slowly, slowly until the consciousness is gone. And then stage 2 is a stage of delirium. Delirium is the same as basically someone becomes excited, they are moving like that. So in this stage, there is lots of consciousness. It starts from the loss of consciousness to the beginning of irregular respiration. Okay, remember, you have irregular blood pressure here, increased respiration in stage 2. So it's starting from the point when you've lost consciousness to the beginning of irregular respiration. Okay, excitement is going to be seen in this stage, and muscle tone is going to increase. So the jaws are going to be tightly closed. The heart rate and the blood pressure will also get to rise. So the jaws are tightly closed at this point. Muscle tone, remember, has increased. It is in stage 3 that the muscle tone now gets to drop again. All right, so stage 3 is the surgical anesthesia, and it's the extent from the onset of the irregular respiration to the cessation of spontaneous breathing. Spontaneous breathing, this is the normal breathing that we have that happens by itself. So when the irregular respirations to the point when you can't breathe by yourself, and it's divided into 4. You have got the plain one, which ends when the eyes become fixed. Plane 2, there's loss of corneal and laryngeal reflexes. The corneal reflex, like if they touch your cornea, you don't try to close your eyes. Okay, and then in plane 3, the pupils start dilating and the light reflexes cease. Like if you try to pass a torch in the eye, the pupil is not becoming smaller, and this actually happens when someone is dead. And then in plane 4, the pupil is dilated, there is also decreased muscle tone and BP. And then stage 4 is medullary paralysis. Here the respiratory and vasomotor control ceases, so someone can likely die there. Okay, so those are the phases. Now general anesthesia, the drugs that you use here in general anesthesia, they are divided into two. You have got those drugs that you can actually give them as an inhale, you can give as a mask. Okay, like you just give someone a mask, you are talking to them, they are in a mask, and then suddenly you just see them going slowly, slowly, and then they can't respond anymore. You understand much of this when you start seeing patients on the ward. Okay, that's the inhalation. Some of them are given intravenously. For example, someone has just been put on a cannula, they have got a cannula, and then the drug is going through. Okay, that is intravenous. So the inhalational ones, you have got the gases and the volatile liquids. Remember, this table came in our test. Anyway, so inhalational, you have got a gas and volatile liquids. Please, you need to know examples of inhalational anesthetic gas agents, and then the intravenous. So for the inhalational, the gas is nitric oxide, and then for the liquids, volatile means something can easily convert to gas. For example, the way spirit is. Once you leave it open, it's going to convert to gas. So examples of inhalational liquids, you have got halothane, enfluorine, isoflurane, desiflurane, sevoflurane, methoxyflurane. You can see they basically end in fluorine except halothane. All right. So these are the inhalation ones. And then the ones that you give IV intravenously, you have got the slower acting and the inducing agents. To induce means that these are the ones that you'll be able to use to start really the process of anesthesia. So for the inducing agents, you have got thiopenton, methotrexate, propofol, etomidate, okay, deximed, dexametho, dexmedetomidine. But here the common one, you have got etomidate, propofol, thiopentonon. At least try to remember these. Okay, propofol, etomidate, thiopenton. Now for the slower acting, they are divided further into dissociative anesthesia, opioid, and benzodiazepine. The dissociative, you have got ketamine, and then the opioid. The opioids, remember, these are guys that you also give for pain relief. You have got fentanyl, which is one of the most common abuse in the United States, causing a lot of deaths. You just find someone is dead. They are abusing fentanyl. And then the benzodiazepines. Benzodiazepines, the way you recognize them is that they have got a Z in them. So I've got diazepam, lorazepam, midazolam, okay, all these. And these drugs are actually going to be used in conditions like seizures, epilepsy. That's you give benzodiazepines for those conditions. So this is the class of the drugs. Okay. So take note that all inhalation anesthetics will increase intracranial pressure. So you don't give them in head injury. And then all intravenous anesthetics will decrease intracranial pressure. There's an exception of ketamine and the opioids. Okay, these ones will end up increasing intracranial pressure. Now, how do general anesthetics work? The mechanism of action of general anesthetics, there is no specific receptor where they bind. Okay, the fact that chemically you have got a lot of chemically unrelated compounds which produce anesthesia, so that means there is really not a single receptor where all of them can work, because you have got different types of these guys that can really produce anesthesia. Now the focus is on different proteins comprising of channels. For example, you have got a GABA A receptor, glycine receptor, NMDA glutaminergic receptor, nicotinic receptor, and the serotonin 5-HT3 receptor. So these are some of the receptors where the general anesthetics will work on. So you can see this receptor that you can see here is a GABA receptor. Now you can see that GABA A receptor has further different subunits. Okay, you have got the alpha, the beta, the gamma. So take note that alpha receptors, that's where ethanol binds. That's why ethanol also in the past could also be used as an anesthetic, just make someone drunk. That's why for a person that is drunk, they can step on fire, they're not feeling anything. It's also anesthetic because it also binds on this receptor. Now for the beta subunit, that's where GABA itself, that inhibitory neurotransmitter, actually binds, okay, on the beta subunit. And then the benzodiazepines will bind on a different subunit, okay, the gamma subunit. And then you can see on the beta subunit, you have got other drugs that bind on the beta subunit, like the neurosteroids and barbiturates. So what's important for you to take note is that the benzodiazepines work on the GABA receptor, but not specifically where GABA binds. GABA binds on the this beta receptor, but these benzodiazepines will not really bind on that. Instead, they work on the gamma receptors. Please take note of these receptors. So, for example, Some drugs that work on the glutaminergic receptor NMDA, you have got nitric oxide and ketamine. Okay. So when you look at these receptors, you have got some of these receptors are who are inhibitory, others are excitatory. So what you are trying to do is for the inhibitory receptors, you want to enhance them so that you can prevent pain and cause anesthesia. And then the excitatory receptors should be inhibited. So the inhibitory receptors, you have got GABA A and glycine. So these ones are going to be enhanced. Okay. While the excitatory receptors are going to be inhibited. For example, you have got a nicotinic receptor. Okay. So they are going to be inhibited, and then you have got the NMDA receptor, the N-methyl D aspartate. This is a glutaminergic receptor. It's also going to be inhibited. Take note that general anesthetics do not combine with GABA receptors, really. Not the receptor, because GABA, how does GABA work? When GABA binds to the receptor, it is going to cause the entry of chloride, and so there's going to be hyperpolarization. If there's hyperpolarization, it becomes hard for you to cause contraction of muscle, to cause pain and such. Okay. Now these guys, they really don't cause, they really don't attach to the receptor where GABA binds, but they'll simply enhance the function of the GABA receptor by binding to another receptor, as we said earlier. Okay, you can see these guys are not binding to where GABA was binding on the beta subunit, but they are binding to other parts like the gamma subunit so that you enhance the function of GABA. Now, you have got these different drugs and the receptors where they work. So you have got GABA A receptors. So the GABA A receptor is going to be potentiated, or there are some drugs that will potentiate, that will strengthen the binding of GABA to the receptor. That includes halofen, propofol, etomidate, enflurane, isoflurane, desiflurane, sevoflurane. And then you have got those that binds to NMD receptor and inhibit it, like ketamine, nitric oxide, and xenon. Basically, these inhalation ones. Okay. Ketamine is not inhalation, by the way. Okay. Glycine receptors can as well be, so these are the ones that can potentiate glycine receptors. You can see that those which are potentiating GABA receptors, majority of them are also potentiating the glycine receptors: halothane, propofol, enflurane, isoflurane, desflurane, sevoflurane. Not like you should really must, but take note that different drugs will, some of them will potentiate or strengthen the GABA binding, others will strengthen glycine binding. Okay. So currently there are 5 inhalation and 5 intravenous general anesthetics to induce or maintain general anesthesia. So the inhalation ones, we've got nitric oxide, xenon, isoflurane, desflurane, sevoflurane. And then the IV ones, we have got propofol, etomidate, ketamine, methotrexate, and thiopento. So these drugs are going to be used to induce anesthesia and also to maintain anesthesia. And of these 10 general anesthetic drugs are going to be accompanied by sedatives, drugs to depress the nervous system, basically the benzodiazepines, midazolam, diazepam, lorazepam. Okay, so these will be accompanied by them. So of the 10 general anesthetics, 3 of them, which is ketamine, nitric oxide, and xenon, will be able to inhibit the NMDA receptor subtype, and they also have modest effect on the GABA A receptor. And while the other 7 anesthetics and the 3 sedatives, like the 3 benzodiazepines, will share a common target mechanism. Number 1, they are going to enhance the function of GABA A receptor. Number 2, they will work on the glycine receptor. Number 3, neuronal nicotinic receptor, and then the 5-HT3 receptor, which is serotonin. and then glutamine receptor, and then also on potassium channels. So please remember that general anesthetics will actually work on potassium channels. When you open potassium channels, potassium will start leaving the cell, so the cell becomes hyperpolarized, and that is going to cause anesthesia. Glycine, you know what happens for glycine? It is inhibitory neurotransmitter. GABA is also GABA is also inhibitory. Nicotinic receptors, these ones are going to be inhibited because they're excitatory. And then you have got the serotonin and glutamate, these are also going to be inhibited. Okay. So when you are giving anesthesia, there is the induction, maintenance, and recovery. Induction is the time elapsed between the onset of administration of the drug and development of effective surgical anesthesia, or stage 3. So induction is you've given the drug up to the time that the drug starts to work as you want it on stage 3. Maintenance is now time during which the patient is anesthetized. So that time when they have been kept in stage 3. Recovery is the time from discontinuation, when you stop giving the anesthetic drug until they gain consciousness back. All right, so that is it, recovery. So is this okay so far? Okay. So in a elation anesthetics, these ones are going to be delivered via the respiratory system. You have got nitric oxide. Now, that's the first one. Nitric oxide is a colorless, odorless gas at room temperature. It's soluble in blood, it mixes in blood and other tissue. Okay. So, nitric oxide has the lowest solubility, the fastest induction and recovery, meaning that immediately you give it, someone will easily become, go into the state of anesthesia. Okay. They're going to just shut off very fast. And also recovery. Okay, if you stop giving it quickly, someone will recover. It has got the highest mark and is the least potent. You understand what mark is, and it's the least potent, meaning that of all the anesthetic drugs, this one is not that very strong. So there's rapid induction of anesthesia and rapid emergency following discontinuation. It's completely eliminated by the lungs, because remember it's in inhalation. So there's also weak anesthetic but powerful analgesia. It is a weak anesthetic drug. Remember, it's the least potent, but it's a powerful analgesic. It stops pain, and it causes, the problem is it can cause megaloblastic anemia. So it is used as an adjunct to supplement other inhalationals. So you are just add on top. Remember that it has got the highest mark. Okay, we'll discuss what mark is. So what are the side effects of this nitric oxide? Diffusion or hypoxia. So can cause which is a respiratory disease. There's hypoxia, really. There's that drop in oxygen. Okay. There can also be nausea and vomiting. Inactivation of B12. So that is what causes megaloblastic anemia, because there's inactivation of B12. It can also suppress bone marrow. That can lead to leukopenia. Okay, the drop in white blood cells if you use it chronically. Also, can lead to abortion on congenital anomalies. Okay, the contraindications: when should you never use nitric oxide? In pregnancy, because it is a uterine relaxant. So what will happen is that in pregnancy, if you end up relaxing the uterus, so that's a problem, because, well, if you contract the uterus very much, you can cause the baby to start to be pushed. But at the same time, if you relax it very much, it's also a problem. Okay, because there's always a point in time when you need relaxation and when you need the contraction. So basically, avoid it in pregnancy. When someone is about to give birth, you want to make sure that the uterus contracts. When they are, of course, just working properly, it should be relaxed so that the baby can expand, like that, it can grow. So when someone has got pernicious anemia, don't give them this drug. Pernicious anemia is because of they are basically antibodies that are released, produced against the parietal cells of the stomach, and so there is no release of intrinsic factor, and that causes no absorption of vitamin B12 that results in macrocytic or megaloblastic anemia. Remember, these drugs also cause megaloblastic anemia, and don't give them if someone is immunosuppressed. The next inhalation one is for halothane. Halothane is volatile at room temperature. It can easily evaporate and slight sensitive. It has got a high fatty solubility, okay, leading to slow induction and recovery. It can actually things that have got high fat solubility. This tells it can easily get to cross the barriers. So it is eliminated also via the lungs unchanged, and is commonly used in children where preoperative placement of an IV catheter can be difficult. It has got a pleasant audio, that is why you can easily give it to children. Okay, where it is difficult to put an IV catheter because children sometimes it's very hard. And then it is broken down by cytochrome P450 to a toxic metabolite which is trifluoroethanol. But this metabolite is harmful to the liver, and so you want to avoid to giving allothane in liver disease. Okay. The side effects of allothane on the cardiovascular system, it will sensitize the heart to action of catecholamines. Catecholamines basically increases the blood pressure. These guys are going to cause the heart to start contracting very much fast. What are catecholamines? These are basically the adrenaline, the noradrenaline. So it will sensitize the the heart to the action of these. So it will worsen or result into arrhythmias, depression of myocardial contraction, and such. On the respiratory system, it will cause the depression of the respiratory system. On muscles, there will be what is known as malignant hyperthermia. Okay. And then kidney, there will be decreased renal blood flow and reduced glomerular filtration rate. On the liver and the GIT, it induces hepatitis, inflammation of the liver, nausea, and vomiting. There are some drug interactions. Allothane can interact with theophylline. You understand this drug as we get to discuss the treatment of these respiratory conditions. Okay, like when we'll be discussing the treatment of which condition is that? Not asthma, but as we'll be discussing the treatment of that should be COPD. Okay, so we'll be able to discuss theophylline. So allothine will be able to interact with this theophylline or adrenaline and may precipitate arrhythmias. Basically, you can worsen the condition. Contraindications again, hepatic dysfunction or jaundice and pheochromocytoma. In pheochromocytoma, what happens here is that the chromaffin cells or the C cells or the adrenal medulla are producing too much. It's actually a tumor that is producing too much catecholamines, adrenaline and noradrenaline, and so that worsens. If you give these drugs to someone that has got a pheochromocytoma, there's going to be even a big problem because already this drug sensitizing causes the heart to be more sensitized to catecholamines and resulting in arrhythmias, and those are not really good. Sevoflurane also has a pleasant smell, so you give it in pediatrics. Okay, it's a drug of choice and it's non-irritant and will cause bronchodilatation. It's a second agent of choice in neurocardiac anesthesia and in the asthmatics. So rapid onset and also recovery to start so fast and to recover so fast. So it has got low solubility because those that are fat in nature or lipid in nature, they have got high solubility and they have got a slow onset and slow recovery. Enflurane has a pungent smell. It is metabolized to fluoride and excreted in the kidney. So it can actually be nephrotoxic. So want to avoid it in kidney disease. The adverse effect is CNS stimulation. So it will produce epilepsy like seizures. So when you want to tell that someone has got epilepsy, really you look at an EEG. So there will be abnormalities on the EEG. Epilepsy is basically having convulsions at more than two convulsions at least in 24 hours. We call that as epilepsy. Seizure, basically epilepsy are more than two seizures are happening 24 hours apart. Seizures is where we have just abnormal firing of the brain, which results in tonal abnormal contractions which are uncoordinated. So, what are the important characteristics of inhalation anesthetics? The solubility in fat. Okay, they have got solubility in fat, and that is called the gas partitioning coefficient. And then solubility in blood, that's known as that is blood gas partitioning coefficient. So there is the oil gas partitioning coefficient and blood gas partitioning coefficient. The oil one that tells with describe the solubility in fat. So so the oil gas partitioning coefficient, remember the partitioning coefficient is basically the solubility. So if we say oil gas partitioning coefficient, it just indicates the amount of gas that is soluble in oil phase. So it is a measure of lipid solubility of anesthetics, the amount of gas that is soluble in oil phase. Okay, and so it measures the potency of the drug, while the blood gas partitioning coefficient is the ratio of concentration of blood to the concentration in the gas. Okay, concentration in the blood to the concentration in the gas. So don't much worry about it, but just take note that the oil gas partitioning coefficient just tells you about the potency, but not really that you should master anything or worry much about that. And then you have got what we call the Mach value. So what is Mach? It is the concentration of inhalation anesthetic that produce immobility in 50% patients. Okay, in 50% patients in response to surgical incision. So concentration of inhalation anesthetic that will produce immobility in half of the patients. So the lower the Mach value, the more potent the drug is. It means that you only need a small concentration for immobility to be produced. Okay, so it is decreased. The Mach will be decreased by CNS depressants and also in AID people, and increased by CNS stimulants. Remember, we said that nitric oxide has got the highest Mach value. That tells you that it is the least potent. Okay, and as you can see here, you have got methoxyfluorine. It has got low Mach value of 0.16, meaning that it's the most potent. And then nitric oxide, the Mach value is greater than 100, so it's the least potent. So those we've discussed are the inhalational anesthetics, but the intravenous anesthetics, there's no need for special equipments really, because you are just infusing in a cannula or putting in blood. So there's rapid induction and recovery, except the benzodiazepines. All right, they take a bit of time, and you inject these ones slowly. Okay, compared with inhalation ones. Recovery is due to redistribution from the central nervous system. What happens is that when these drugs, when you've injected them in blood, they'll go to the central nervous system. Now, from the central nervous system, the drug is going to be redistributed to the entire body, and that is what will cause the recovery. So, analgesic activity is going to be produced by opioids and ketamine, while amnesic action is by benzodiazepines. Like amnesia, you go quiet, like you want to sleep. That one is going to be produced by the benzodiazepines. Also, ketamine can produce amnesia. Okay. So take note that patients with hypovolemia or shock suffer from severe hypotension. If someone has got hypovolemia or shock, they have got basically little fluids in circulation, and so there is hypotension. So you can give them barbiturates, propofol, etomidate, and benzodiazepine since they decrease blood pressure. These drugs will decrease blood pressure. Okay. Now, it's not like we can't give them this because they decrease blood pressure. And someone that has got a hypovolemia already has got a low blood pressure. So we can give them ketamine because it's the only one that increases sympathetics. Ketamine is the only one, take note, that will increase the sympathetics, and so it will increase blood pressure. So it's the only one that you can give in that condition. So we have got what we call the ultra short acting barbiturates. The barbiturates include the thiopental and the methotrexate. So these ones are barbiturates. Remember the barbiturates we are also potentiating, okay, by working on which receptor, that was the alpha receptor, potentiating the effect really of the GABA A. So if you see here, so basically working on the beta receptor really. The same receptor where gamma works, the alpha subunit is ethanol there. So the barbiturates also work on that one. Okay. So the adverse effects of these barbiturates include the severe collapse and respiratory depression. They can precipitate porphyria attack. They are enzyme inducers. And then there's also hypersensitivity reaction risk of vasospasms. If you accidentally, instead of injected in a vein, inject in the artery, they can cause vasospasms, contraction of the blood vessel, and so that reduces blood supply to an organ. They can also depress cerebral blood flow, decrease intracranial pressure. They can also cause tissue necrosis, and that can result in gangrene. Okay, like an area, especially the foot, is not being supplied with blood, and so it ends up dying. They can also be built up in adipose site or adipose tissue. Okay, so there's very long emergency from anesthesia. So they build up in adipose tissue. Now, ketamine is an example of these inhalational drugs. It's a dissociative anesthetic agent which works on the NMDA receptors. It's a potent bronchodilator, so you can use it in asthmatics, and it is a cardiovascular stimulant. Okay, this drug will stop pain. It will also cause someone to go into sleep with loss of consciousness, and it's used for anesthetizing patients at risk of hypotension or bronchospasms. Okay, because it's a bronchodilator and also it increases blood pressure. And also post-operatively, it can cause hallucinations, vivid dreams, and disorientation and illusions. Okay, so after someone use ketamine, they're going to be having hallucinations. No, I'm seeing this one, I'm seeing this one, I'm seeing this one. Okay, those are hallucinations or bad dreams, or they become disoriented, or they are going to be having illusions. Propofol has got a rapid onset and they've got a short duration of action, and is highly protein bound or can metabolize by conjugate enzyme in the liver. So it's used for induction maintenance of general anesthesia and sedation, and it's a very good anesthetic for induction and maintenance with no accumulation effects. Okay, if it accumulates. So the side effects includes pain at the site of injection and also hypotension, just like the others except ketamine. So, if something is highly protein bound, it means that mm, it can have a lot. So, if majority of it is actually bound, let's say, for example, in liver disease where you don't have protein, it means that this one is going to accumulate, so you have to adjust the dose. So, that is it on the general anesthetics.